Welcome to the CAA 2021 webinar series. Today's webinar is Mastering Operation of Mechanical Chest Compression during CPR, presented by Professor Lars Wik and proudly supported by Stryker. Thanks for joining us and we hope you enjoy.
Hi, my name's David Waters and welcome to the latest in the CAA webinar series. Today, our topic is Mastering Operations of Mechanical Chest Compressions during CPR. This webinar is proudly supported by Stryker. Our speaker today is Professor Lars Wik. During this webinar, Professor Lars will discuss the challenges faced during resuscitation and the role mechanical chest compression devices play. There will be a particular emphasis on best practice during resuscitation and will facilitate an interactive session at the end of the Q&As. Professor Wik is a senior consultant in anesthesiology at the University Hospital Oslo and a senior researcher at the Norwegian National Advisory Unit on Pre-Hospital Emergency Medicine, or NARCOS as it's known. Lars also holds a position as a senior researcher. He actively practices clinical pre-hospital emergency medicine and conducts advanced research on cardiac arrest and trauma whilst working with the manned Dr. car in Oslo. In addition, he has regular shifts at Oslo University Hospital Anesthesia Department, and since 1985, Lars has been active in conducting clinical and experimental research into mechanical CPR. He was the principal investigator for the CIRC randomized controlled trial and led several clinical outcome studies that have resulted in the change of resuscitation guidelines. Lars' work has generated contributions to about 100 publications, including JAMA, Circulation and Resuscitation, resulting in several invitations to present at congresses run by the European Resuscitation Council and the American Heart Association. Lars also holds several patents related to emergency medicine technology. I'm sure you're going to enjoy Lars' presentation, and please stay with us at the end for the live Q&A session. Make sure you record your questions in the chat box function as we go, and we will get Lars to answer them. Again, a huge thank you to Stryker for sponsoring this presentation. Welcome, Lars, and we look forward to your presentation. Thank you.
So thank you very much, everybody, for inviting me to share with you this talk, which is called Mastering Operation of Mechanical Chest Compression during CPR, with a particular emphasis on best practice. Here you see how I have planned this lecture. I will talk about the guidelines and the updated ones during the present pandemic, how blood is pushed forward during CPR, the results from the 3 randomized clinical trials, challenges with CPR, subgroup analysis based on the CIRC study, and my experience with focus on ventilation, push point, and pit crew operation philosophy. And of course, probably some provocative views and comments. So what does actually the guidelines say about mechanical CPR? It says that it is not recommended for routine use, but as an alternative when high quality manual chest compressions are impractical or compromise provider safety. In addition, it is indicated during persistent VFVT, transport, or prolonged CPR, like you may have in hypothermia, hypokalemia, anaphylaxis, or pulmonary embolism. But both American Heart and European Resuscitation Council recommended that the use of mechanical devices during the pandemic could be done. But consider stopping CPR early if treatable, reversible causes of a cardiac arrest have been addressed. These slides here shows you how many devices that are out there. It is more than 35,000 now, and we know that people are using these devices. That's the reason why we can't ignore the quality of the use, and that is one of the focuses I will share with you during my presentation. Remember, different machines take advantage of different principles for flow augmentation. You all know these, of course. This slide illustrates the cardiac pump theory on the left, which is the same theory that Lucas and Corpel's CPR is based on. And on the left and the right, we see the circumferential compressions, which is illustrated here with the West CPR. A mixture of these explains how autopulse operates. I illustrated that here with a sternal pump on the left, which is Corpel's, as I said, and Lucas, and on the right, the autopulse. But this is the basis for both theories, that the chest is a spring and that we actually arm this spring when we push the chest. And all of you can then understand what will happen with armoring of the spring if you have a lot of rib fractures, sternum fracture, and in the worst case, a flail chest. There are 3 randomized clinical studies which recently investigated the outcomes when comparing mechanical with manual. And these are the LINK study, where Sten Robertson from Sweden was the primary investigator, the mechanical versus manual chest compression paramedic study from United Kingdom with Professor Gavin Perkins as the principal investigator, and the CIRC study with autopulse, where I was the principal investigator. And we see here the results of these 3 studies. We see that the outcome was similar between the manual and the Lucas device, and manual and the low distributing band / autopulse device. But there is something that doesn't say here, and that is that 30,085 patients were screened together in these 3 studies, which is 11,295 patients included. So we have a huge number of patients documenting how mechanical and manual CPR is actually working in the real situation. We also know that in these studies, they reported similar injuries between manual and mechanical, both for the Lucas device and the autopulse device. There is something I will share with you, and that is that if you put on the device wrongly or suboptimal, you should not wait until the next pause before you adjust it. There are a number of situations where mechanical CPR has been provided, like PCI, anaphylaxis, organ donation, prolonged CPR, hypothermia, and the bridge to different sophisticated treatments such as ECMO, heart-lung machine, aorta balloon pump, and Reboa. There are some challenges with CPR in general, and also, of course, with mechanical CPR, which I will share with you now. In this mannequin study, transportation down the stairs was tested for mechanical chest compression with Lucas and manual chest compressions performed by male and female paramedics. In the mechanical group, rate and depth were significantly better than manual, and there was a difference between gender performance, as we see here, and highlighted with the red circles. Others tested 4 different devices: the manually operated Animax mono and the automated mechanical devices Autopulse, Corpel, CPR, and Lucas 2. And these were tested in a transport with a soft stretcher or journey involving a staircase. And they also looked at loading and unloading. The endpoints were correct pressure point displacement, frequency or correction after slipping, proportional compression meeting guidelines pressure depth, frequency stability, compression ventilation rate. We see that correction of pressure point was required in 83% for the manual Animax and only 11% for Lucas. For all mechanical devices, 30:2 ratio was okay in 87 to 93% of the cases. Let us see a video of transport CPR produced by Professor Ristagno in Milan. Staying alive, we heard there. And it was very, very easy to see that Giuseppe Ristagno in the right video, dressed in white, had a much easier transport than those guys on the left. And I'm sure that all of you out there have experienced this before. Here we see transthoracic impedance and arterial blood pressure during static and transport for Lucas 2 and manual CPR, based on the video we just saw. Recognize that blood pressure disappeared during manual CPR here and transport, which you can see on the lower right panel. Here we see the effect of this. Coronary perfusion pressure, end-tidal CO2, systolic arterial pressure, diastolic arterial pressure is lower in the manual group compared with mechanical CPR. But there are some challenges related to all the shapes of chests out there, illustrated by these 4 pictures. But also connected to pregnant women, and I add men. Maybe they should be resuscitated in the same way as pregnant women should. Due to vena cava syndrome, they should be resuscitated as follows. Lift the torso up 30 degrees, put the Lucas board towards the patient's back aligned to the axilla. Lay the patient down, attach Lucas and lock the piston. Piston is on the sternum close to the xiphoid sternum joint. The space between the Lucas support legs and torso must be filled so that the device does not slide. So you put the patient with Lucas deployed in the left lateral decubitus position of 15 to 30 degrees angle. If possible, anti-Trendelenburg position, and if using backboard, the Lucas board must be fixed with strips so that the left lateral border of the backboard aligned with left support leg of Lucas. This will facilitate lateral decubitus and anti-Trendelenburg position. I will now share with you some of the subgroup analysis we did with the CIRC study, illustrating how we should perform CPR in the future with mechanical CPR. This slide here shows intra-arterial blood pressure in yellow, and the green one there is actually transthoracic impedance that shows when chest compressions was provided. Where the pencil is, we administered 1 milligram of epinephrine or adrenaline. It took about 30 seconds, and then the systolic arterial pressure increased significantly. And in this case, it went up to 300 millimeter of mercury. And we have also seen close to 500 millimeter of mercury. So I put a question mark between that we blindly administer 1 milligram of adrenaline, because I know that sometimes we are very, very high in blood pressure, and that is probably not good for the brain. Here we see analysis where we looked at when mechanical CPR came in with positive effect compared with the manual CPR. After 16.5 minutes with CPR, the mechanical group left the manual group in odds ratio for survival to discharge after 16.5 minutes, as I said. But you can't wait 16.5 minutes and think that you will harvest the benefit of this. You need to put it on from the very beginning. This study here illustrates the pre-shock pauses, the post-shock pauses, and we all know that there should be as short as possible with pauses related to countershock or shocks. We did a study where we looked at these pre-shock pauses and divided them into less than 10 seconds, 10 to 20, and 20 and over. And we see here that for both manual and mechanical CPR in this group, we had pretty good success rates with the termination of ventricular fibrillation. The impact of ROSC and neurologic outcome requires further investigation in this study. But interestingly, in the mechanical group, we thought accrued to shock through compressions. And the shock success then was, as we see here, 78% for initial VF, and all initial rhythms about 79%. And this is much lower than the 80 to 90% success we achieved when chest compressions were paused. How this will influence our results are unknown, and will this be influenced by where in the compression-decompression cycle the shock hits? Dr. Steinberg investigated this and found that shock success was significantly lower for the first shock when hitting the compression phase of the compression-decompression cycle, and for up to 3 shocks also. So shock through compression was not documented, was not a good thing here in this study. And guidelines recommend short period of CPR followed by analysis and shock. Nothing should delay the first shock, and shock should be delivered during a chest compression pause until automatic technology is developed and tested. Ventilation is important during CPR, and there is a need for a focus on that. Ventilation disturbs compression. Positive pressure ventilation hinders development of negative pressure at recoil, and it also hinders venous blood circulation to the right heart. It decreases or hinders positive hemodynamic effects of chest compressions, but it prepares for gas exchange, and it simultaneously compression and ventilation will give you the big bang, as I call it. And this big bang happens when compressions hits ventilations, results in enormous positive intrathoracic pressure, creates barotrauma with alveolar damage, bleeding, pneumothorax, and chest compression generated cardiac output goes towards 0 because of obstructed venous return during diastole. Mechanical chest compression create higher pressure than manual and increase the possibility for the big bang with wrong ventilation. Injuries are also common during CPR, and Smekal found similar rib and sternal fractures between manual and mechanical CPR. Costa performed a CT and autopsy trial where manual CPR was quality assured by accelerometer. They concluded that Lucas does not cause significantly more serious or life-threatening visceral damage than manual CPR, as shown here, and no difference between the manual and the Lucas in clinical perspective. So now let's look at something that most people are not aware, and that is the push point, which is directly related to quality of chest compressions. There is a need for evaluation of blood flow during CPR. We have indirect measurements such as end-tidal CO2, intra-arterial blood pressure, intra-arterial waveform algorithms, cerebral oximetry, but wide use of intra-arterial blood pressure may be challenging due to advanced skills needed and costs. End-tidal CO2 is, on the contrary, cheap and easy to put on the patient, and it should be used all the time. Does it matter where on the chest you push, and why do we push, is the question. The answer is to hit the ventricles, and they are lower than the internipple line based on MR investigation and CT scans of a number of chests. Therefore, we must push on the lower end of the sternum. Charts show that this increased systolic pressure, mean arterial pressure, and tidal CO2. And 3 emergency docs from US focus on this issue in the following video.
And he was shocked, and then he'd go back into arrest and so forth. And at one point during CPR, probably about 50, 60 minutes into the arrest, we noticed that things weren't looking so good on the transesophageal image. And we got an image that looked like this. So that left ventricle, so this is a long axis view, and you can see the left ventricle right here. And it just doesn't look like it's compressing that well. And furthermore, if you look at the aortic outflow tract, it is opening a little bit, but it just doesn't look nearly as good as it had in the previous images during this arrest. And we looked at the art line and saw that it was about 60/30, 65/30, and decided that that was less than ideal. And when we looked externally at our Lucas device, we noticed that it had slid just during the commotion of the arrest, the starting, the stopping, everything going on, the different procedures. Our device and our placement of our external compressions was moving. And
so it had it. Real quick, just tell me, where did you initially place the Lucas device? Was it at the inner nipple line? Was it somewhere else?
Yeah, so pretty much at the inner nipple line, kind of right over the sternum.
And then it slid further up the sternum, like towards the clavicles.
Yeah, and in my experience, I think it does tend to slide superiorly. I can think of a number of arrests where we had to stop the device and reposition it, and I think that's
I've had the same experience.
Pretty normal. So once we noticed that this was giving less than adequate perfusion, and we saw this on our echo, we decided to change it, and we moved the device about 3 centimeters inferiorly and got an image that looked like this. And what's really impressive about this is the immediate change in the art line pressure. So we saw a pressure of 112/32 at that point, and you can see that LV there is compressing a lot more, and more significantly, that aortic valve is opening more. So we see the images that demonstrate that the external positioning is actually changing the point of maximal compression. And here you can see kind of side by side. On the image on the left, it looks to me like that point of maximal compression is like over the LVOT. And on the right, so right over the LVOT, that's
so sort of right in here. You feel like the compression's coming in right over the aortic valve almost, or the left ventricular outflow.
This has been documented in this study, which show that successful resuscitation was achieved when left ventricular outflow tract was open. Let us look at some important aspects related to mastering operation of mechanical chest compression from a practical standpoint, which I call CPR CRM. This illustrates the pit crew operation of integrated mechanical CPR. To achieve this, we must train. What to train? How to operate Lucas 2, how to deploy Lucas 2, how to operate the stretcher and move and carry the stretcher with Lucas 2. And we also have to look at, we must train the CPR algorithm and when to deploy Lucas according to treatment procedure. Standardized 4 hour and less, actually, we have done it for 2 hours. Training program was developed focusing on reducing hands-off time. They were trained in and practiced the pit crew model of resuscitation, which means that each responder has a predefined role based on their location next to the victim. Integrated manual CPR with Lucas is therefore the key here, and with a standardized deployment method for both the defibrillator and the Lucas 2. Dr. Levy in Anchorage, US, showed that applications time decreased over a 2-year observation time when they focused on this. I have heard also that London Ambulance did the same and reached 11 seconds to put the Lucas device on their patients. They provided updated training scene leadership, completion of 2 cycles before transition to Lucas, standardized application, and resume manual if the device did not work. When arriving, I have the following recommendation for you. Turn on defibrillator and the mechanical device, go through the ABCs, start manual chest compression, put on the pads, put on end-tidal CO2 and the pulse ox, the defibrillation, and prepare deployment for the Lucas device. Cut clothing, lift torso, rip off clothing, put the board on the back, lay the patient with the board on the back down on the ground. Resume manual CPR and simultaneously deploy the device, adjust piston, and start 30-2. So the keywords are defibrillation, ventilation, arterial blood pressure, if you are trained to do that, circulation quality by end-tidal CO2, if you are rich cerebral oximetry, and ultrasound echo Doppler, and if they are indicated, anesthesia and hypothermia. But the last word related to hypothermia is not said. So my conclusions are that randomized clinical studies documented that mechanical CPR achieved the same outcome as manual CPR. A randomized clinical trial to document the bridge effect is not needed, question mark, question mark. Mechanical CPR must be deployed early, but without first shock delay. Deploy the piston low distributing band on sternum chest where you get the highest end tidal CO2. Shock delivering during chest compression should be explored in the randomized clinical trial and the optimum phase of the compression cycle identified. Be aware of that none of the RCTs focused on individual compression point go towards highest end tidal CO2. Shock was delivered without chest compression pauses. Thank you very much for listening, and I am ready for questions. Thank you.
Thank you, Lars. That was a great presentation, a lot of information in that very short period of time. Thank you, Lars. What time is it with you right now?
It's 6:30 in the morning here.
Oh, thank you so much for an early start. The content of your presentation is very important to us in the Southern Hemisphere. So we want to thank you so much for taking the time, to put the presentation together in the first place, but also to join us for this live Q&A session.
I see the question myself, actually, and I have an answer to Matthew, who asked about putting the chest point over to the left. I do not recommend to do that, based on the fact that if you push on some of the ribs, the fracture that may be generated by that will be like two knives getting into the chest, and will probably do injuries to the heart. So keep on the sternum and not over to the sides of the sternum.
That's great. Thank you, Lars. I've got another question there from David, if you can see that one as well.
What is the optimal time during mechanical compression to defibrillate, if any? That's a question that needs the answer. I don't know the answer yet. What we know, and this is actually a speculation, and that is that when you deliver the counter shock at the same time as you do chest compression, could be a possibility that the heart actually slips away from the beam of the electricity that you send through the chest. Because the heart can slip in all kinds of directions in the chest, and as some of you know, it is only 4% of the electricity that we send through the chest that actually hits the heart. So just half a centimeters away from that beam will have a negative effect. But in other words, I think that we have to wait for studies that showing us how the synchronization of mechanical chest compression and defibrillation is done. Manually, it is impossible to do, as we did in CERC study, as we saw. But so I do not have the last answer to when in the cycle to deliver the shock. But what we have done here clinically in Norway, and in particular in Oslo, is that we do not deliver the shock without stopping chest compression for a second or two.
Douglas has popped a question into the chat now. Thanks, Douglas.
How common is it for clinicians to encounter false user error with mechanical CPR causing delays to compression compared to manual compressions? That you don't know, and you don't know even in manual CPR. The only way to do this is to collect electronic data when you are doing CPR and review that later and focus on what is done wrong. And delays are not only common in mechanical CPR, it also is common in manual CPR. So there is only one way to try to solve this issue, and that is to collect data and review it with the crew, or that someone at the scene guide everybody to not stop doing chest compressions.
Reese has got a question there for you.
Yeah, I knew that question will come, and that is the heads up philosophy of doing chest compression. And It is a very, very interesting philosophy here of how blood is moved around. I have not tried the Elegard system myself, but I have seen experimental demonstration of it. And there is a lot of other things that is put into this package, like the impedance threshold device, and that you don't push or you don't put heads up as fast as you could. So let's see what happens. We need some clinical studies, but something which is clear-cut and not rocket science is that if you put the head higher than the lower part of the body, the intracerebral pressure will go down. I mean, that's something we all know. So that is not the proof that this technique works. But yes, it's interesting. Yep, optimal strategy for ventilation during CPR, short, sharp breaths on decompression cycle to avoid big bang. Yeah, 100% agree. That's the only way to do this. I see that some people in the world actually put on mechanical ventilation. That's not something that we do here. And because I know that will create a lot of more barotrauma. What people don't remember is that person who actually is in charge of ventilation cannot do anything else than ventilation in between two chest compressions. There is an alternative, and that is to skip continuous chest compression and go to a ratio of 30:2. That will help you a lot, and we always do that in the beginning of a CPR scenario. Do any mechanical devices also compress and assist chest upward movement in the hope to increase venous return? Very good. The Lucas device do not do that actively. The force of the piston is only 13 Newton, which is very, very little. But we have now in press a publication in resuscitation with mechanical active compression decompression. So that was in press on last Tuesday. So look in resuscitation and you will have the answer to that question, David.
Thank you, Lars. I have a question for you whilst we're waiting for some more to pop into the chat. I was really pleased to see the component of your presentation which talks about the pit crew approach to the application of the device. I'm not sure if you know, but across the whole of Australia and New Zealand, we've adopted the pit crew approach to CPR generally. So this is just an extension of our current choreography in this space. I'm really interested to, and I'll be really interested to see how we're able to add this additional step into our pit crew approach. Do you foresee any challenges in doing that, or should that be pretty seamless?
That should be pretty seamless. The only challenge I see is that people forget to follow the internal guidelines, so to speak. But this is something that should be trained and of course done clinically. And I have seen enormous benefits of doing this. People are more calm if they know what to do, not so hectic, not so chaotic, and the patient will benefit. That's the point. The patient will benefit from it.
Yeah, thank you. And I think it will be a natural progression as we've developed the culture of calmness, control in this space. So it'd be exciting to see. My follow-up question related to this is, one of our large ambulance services is about to roll out a significant number of Lucas 2, several hundred. I'm just interested in your thoughts about how do you do a mass rollout of this device in relation to, I guess, quality, education, and all those aspects, as opposed to just providing another tool?
My life philosophy is that you can't buy success. You have to put these devices into a concept of improving the quality for all cardiac arrest manual and mechanical, which means that if you just put the device out there and lay back and think that everything will be fixed by itself, you will experience that you have done a wrong thing. The reason why I, a few years ago, put this presentation together was that I was so afraid that the distribution of 10,000s of mechanical devices out in the field would not be followed up by a focus on quality of what we are doing. Because it always takes some years before we see that survival rate go down or go up. And one thing that I would not tolerate was that the survival rate went down after a crew or a system implemented mechanical CPR. Because I have personally seen all the benefits of the mechanical CPR, but I've also seen the negative effect of it. If you are not awake, adjust push point when it's needed, and actually know what you do. So my advice is put these distribution of all these devices into a pit crew model, train the crew so that they are sophisticated and understand the upside and downsides of mechanical CPR.
Great, thanks. That's great advice, and I'm confident that will be our approach. But as you know, there's always challenges in large rollouts, so we will focus on that absolutely. You know, the slippage of the position is a well-known challenge. Do you have any tips or tricks about how paramedics can, you know, better monitor, get a better feel when slippage is occurring?
No, but I mean, some chests are not meant for being compressed on because they have a very, very different profile. But after a while, they will get more and more flat. The interesting thing is that for few of these devices, they have not fixed the most terrible slipping, and that is cranially, when the device actually moves towards the neck. Right. Yeah, and that is actually the natural way to move because most chests are in that profile. So just by gravity, that's the way that the device slips. And what we have done there for some of these extreme chest profiles is that actually to hold the device in position. But that is not an ideal situation. But put on the straps, make sure that it doesn't slip. And sometimes actually the suction cup also suck to the chest, so that will help you from that. But don't tolerate and don't wait to the next pause to adjust slipping. That should be done right away.
Great, thanks for that. Obviously in Australia and New Zealand, we have long distances to travel with patients often. I'm just really interested in your observations when we're transporting patients under mechanical CPR for long distances, potentially an hour or more in some instances. Any thoughts or considerations in that space?
Yeah, that is probably possible. We have done that in Norway as well. We have also long distances here. So it is possible. What you have to do is that it could be that you actually move over to 32 when you're transporting in order to be able to give two very quick breaths in between the 30th and the first chest compression, and the monitoring end-tidal CO2 during that trip. But it is possible, and we have had cases, as you may have in Australia as well, with people walking out of hospital after 2 hours with mechanical CPR. So it is possible. The record I had was 5.5 hours.
Wow. That is a record. We're not looking to beat that, but it's a record. Absolutely.
I don't think it's good. I don't think it's good for you.
No. I've got a question back in the chat from Liz, if you can see that one.
Yep. Do you have any advice re-optimizing effectiveness in those patients with very rigid chest case and stage COPD? Very rigid chest case will be handled by most of these devices based on the force they have. The autopulse is a very, very strong band that will be possible to do this in a good way, and both Corpus and Lucas as well. Lucas compressed with 90 newtons, which is very, very much actually. So we have not experienced big difficulties with stiff chests. But of course, what we see here is that they always have end-tidal CO2s, which are very, very high. And usually end-tidal CO2s reflect good flow. But in COPD patients, you should go for an even higher end-tidal CO2 than you do for normal people. So at least 5 kilopascal end-tidal for those patients to be sure that you are actually providing a good blood flow. And the other thing I always do is that I put the pulse ox on the finger, and if I get readings from the pulse ox, oh, that's pretty good perfusion.
Excellent, thank you. I know certainly from my experience, when we train, we're putting these devices onto a very standard 70K mannequin. Very few of our patients appear the same size of our mannequins. Just keen to just explore your thoughts or feelings in relation to the range of body sizes and how well the Lucas 2 performs, and any special considerations from the large extremity, larger bodies right through to the smaller ones.
Yeah, what I'm saying now is not advised by the manufacturers. Just to let you know, and I underline that this is my experience and how I operate the Lucas device when I do it. I have had patients that their anterior-posterior diameter is too small. Mm-hmm. What I do there is that I put 2 fingers in between the upper surface of the chest and the piston, and I put the piston down to that finger, and then I lock it. So what I actually do there is to add a kind of air between the piston and the chest in the beginning, but that will actually create a kind of active decompression afterwards. Not the real one, because it's not forceful enough. But by doing that, like having a gap there of 1 centimeter, I will be able to overcome the safety things of the device. But again, this is not at all advised by the manufacturer. When you have a very, very, very big chest, there is nothing to do. There you have to do manual CPR.
Yeah, we hear obviously stories about patients waking up whilst they're under mechanical chest compression. Just keen to hear your thoughts about how you manage that, best way of managing patients that regain some level of consciousness.
That happens a lot of times, and it's actually very, very good and positive that they wake up, because then you know that they have enough blood flow to the brain. What we do here is that we give them fentanyl and ketamine, so they fall asleep again, because the alternative is to stop chest compression, and that is not a good alternative. You can also add midazolam, so midazolam, ketamine, fentanyl. We never use propofol at all.
Excellent. Do you see any advances? What do you think Lucas 3 is going to look like? And will it address some of the challenges that we've just talked about?
And Lucas 3 is already there, as you know. It's some It's the same as Lucas too, with some more technology inside the head, so to speak. But I don't know what is going to happen. But I am sure that we have not stopped developing better devices for the crew out there and the patients who need them. But at the same time, I'm the one who say that, hey, wake up. This is not a playing tool. It is a dangerous tool that you should know how to operate. The quality of mechanical CPR is extremely important because they could do a lot of harm if they are put wrongly on the patient, and hammering on the liver or hammering on the wrong spot on the chest.
And I think, I know certainly with the services that I work directly with, that they are rolling out really good training, but also they provide the Lucas device to people at a particular practice level typically. So there's some guarantees around the deeper knowledge you need in relation to managing a complex but essential device such as mechanical CPR. It's really exciting times, and I think it's going to make a huge difference. I don't know if you're aware or not, but the whole of Australia and New Zealand and Papua New Guinea were all committed to implementing the 10 steps from Seattle around improving out-of-hospital cardiac arrest survival rates, and particularly in lifting our kind of average 8 to 10% survival rates to something far more meaningful in the not too distant future. And obviously mechanical CPR plays a really important role in lifting our survival rates. I just thought as a closing statement, whether you'd like to comment on how you see survival rates improve as a direct result of mechanical CPR.
Mechanical CPR alone will not improve survival rates. Mechanical CPR in the hands of very well-trained paramedics and physicians will, as a team, increase survival rate. There is a misunderstanding that you can buy survival rates by going to the shop and buy mechanical devices. When you buy a device like Lucas, Autopulse, Corpus, or other devices, you are always buying a kind of bundle of care that comes together with how to operate these devices. So you are not finished by the work. You add an additional training philosophy with these devices. So even though I am one of the most positive guys in related to mechanical CPR, I'm also the most skeptical guy related to mechanical CPR in wrong hands.
Thank you. That's very wise but poignant words. I think we need to take on board, because it rings really true for me. This is a package of care, and every single aspect of that package needs to be perfectly administered for the patient to survive. And we mustn't lose focus on getting that complete package of care right. So thank you for that. And thank you so much for taking the time to talk to us in this live Q&A session. We really do appreciate it. And thank you so much for sharing your knowledge and your wisdom in this space. We will let you continue, I'm sure, your busy day with your early start at 6:30. And again, on behalf of all the attendees, thank you. And on behalf of the Council of Ambulance Authorities, a big thank you also to Stryker for making this webinar possible. Thanks everybody for attending this webinar, and we look forward to seeing you again. And on behalf of the CAA, it's been great to share this hour with you, and I hope you gained some useful information from that great presentation from Lars. Thank you all. Cheers now.
Thank you for attending Mastering Operation of Mechanical Chest Compression during CPR, presented by Professor Lars Wik and proudly supported by Stryker. Also be sure to follow us on social media to keep up to date. Twitter at CAA Australasia and Facebook and LinkedIn the Council of Ambulance Australasia. Thanks again for attending, and we look forward to seeing you next time.